approximately here. This is good?
As long as you can see yourself, you're good.
Okay. Hi, everybody. Thank you for the introduction. Thank you for inviting me. I call this Tuesday with the Kidneys. It's trying to come up with a cute title, and this is what I came up with. Rather than dive right into transplant, I figured it was a little bit better to sort of get some background. Why are people needing transplant? Where is this coming from? How are people? Let's learn something about the kidneys first, and then learn about what diseases hit the kidneys. How do people end up with chronic kidney disease that may end up later on needing a transplant? And then we can talk a little bit more about the specifics in terms of donation and transplant if people want. And obviously, I don't know if anyone's read the book, but it seemed like an apropos connection. Thank you to the Kahila. Thank you for Dr. Bright. Where are you? Where'd you go? Oh, there you are, way in the back. And thank you to Rabbi Stern for making the shidduch here, for having me out. He won't say this, but I will. I knew nothing about renewal until, I guess it's about a year ago,
Exactly.
a year plus ago, when someone in our community in New Jersey donated a kidney, actually the next town over, and there was an article in the paper about her donation, and then talking about renewal being involved in matching people up for donation. I said, this is interesting. I'm a nephrologist. I don't know anything about this. Maybe I should learn something about it. And just very soon after that, Rav Stern held a baton, whatever you want to call it, at my shul. And I said, I got to go. I got to see this. I was blown away with how they look at donors, how they look at recipients. I said, I got to learn more. I went out, actually met with them. I called them up. I said, can we meet? I got to learn something about you. Went out to Brooklyn, met with you, met with Rav Steinmetz. Absolutely blown away. I've never seen an organization that looks at a process the way they do, and look at the donor the way they do, and streamline the process and make it a process that that's going to help a donor through. I took away from there saying, wow, we have to do something like this, and we have to recreate our program, and we have to recreate our systems, whether that's in the transplant center, whether that's in my office. And so we have to look at things through a similar light. And it really was mind-blowing to me, and I really have to thank him just for meeting with me, if for nothing else, just to learn something about them in that way. So who am I? You've heard a little bit about me. I'll give you a little bit more of my yichus. I'm in private practice in Hackensack. My group specializes in general kidney disease. That includes people in the hospital who go into acute renal failure. That includes people that are sent to me in the office. They are found to have kidney disease by their primary care doctor. We tend to do a lot of what we call the nephro-oncology at Hackensack. Hackensack has a huge cancer center, a huge regional cancer center now. And my group tends to do much of take care of many of the kidney problems that arise from chemo, from the treatments that come with cancer treatment. I personally specialize in kidney stone prevention and electrolyte disorders, in addition to being the donor nephrologist for the hospital, which means that I and my partners evaluate the donors. Anyone who wants to come and donate, either altruistically to a family member, we're the ones that evaluate the vast majority of the donors coming through the hospital, making sure they're healthy, make sure the kidney's healthy, make sure it's okay for them to go through surgery. I'm a little bit more of a yichus if you want. I'm from the University of Pennsylvania, from Cornell. I did my residency at the Shomer Shabbos program at Rutgers, and my fellowship here in New York State at New York Medical College. And of course, no good talk would be complete without a picture of the family. And this is just from a couple weeks ago at Rocking Horse Ranch during Yeshiva Week. So, my shul in Teaneck doesn't know me so much as kidneys. They know me more as a Shliach Tzibor for Rosh Hashanah. And they know me as the one that comes up with all these fun ideas for their Siddharim and gives talks at our shul right before Pesach. I'm happy to talk about that also.
They're very good. I've used them.
That's the other passion of mine. Okay, let's actually talk about kidneys a little bit. What are the kidneys? Kidneys are a little bit small organs. They're about 4 to 6 inches, which, if I remember, my hand is about the size of my hand. They fit right here in the back, right behind the ribs, and they poke out just a tiny bit below the ribs. So people come to my office and they say, "I got kidney pain down here." No, the kidneys actually sit up a little bit higher. I have a picture down on the side. The kidney being shaped. My kids, as they're listening to me practice this talk, wanted to know which came first. Were the kidney beans named first, or were the kidneys named first? I'll leave that for a vote by the audience. What do they do? You know they're there. What do they do? And everyone knows they filter toxins. They're really involved in a lot of systems in the body, and a lot of complex systems in the body. They obviously filter toxins from the blood. These are the water-soluble toxins in the blood. They regulate salts, the electrolytes, the salts in the body, and they balance those in the body. They're involved in maintaining blood pressure in the body. They're involved in making sure that the body has the right number of red cells. The hemoglobin, you may have heard that from your doctor. They're involved in making sure the bone marrow is stimulated properly in that regard. They're involved in regulating fluid and water in the body. And they regulate the acidity levels in the body. All these things, very complex systems that need to be regulated very, very closely. Kidneys are involved in that. It's amazing. These tiny, tiny little organs, size of your hands, are involved in doing all these complex processes. Let's take it down a little bit. Let's take it down a step. Let's look at the kidneys anatomically. There are a couple parts to the kidneys. Sort of general parts. There's the glomerulus, and that's these little squiggly lines up here. They're the tubules. You can see some of them down here. The dive down is the cortex.
You can use the pointer.
I can use the pointer. I said I wasn't going to use the pointer. The cortex is out here. That's where the vast majority of the filtering of toxins takes place. The tubules, there's some tubules in the cortex, and they also dive down to the medulla. And that's where the vast majority of regulation of fluids, electrolytes, salts, acid base takes place. The interstitium, there are all the cells and the in between all these things. Then the vasculature, makes sense, that's the blood vessels coming in, the blood vessels coming out. And the collecting system. Well, after we make urine, after we filter the blood and we make urine, it's got to be collected somewhere to go to the bladder, and that's the urinary collecting system. A little bit more detail. So a glomerulus is the blood vessels come in to the kidney, and then they dive into the cortex, and they form this, for lack of a better term, a squiggly bunch of capillaries that are under high pressure. The blood comes in, it's under high pressure, and the liquid part of the blood, part of the blood gets forced out of these capillaries. Capillaries, microscopically, have cells on them that have little holes through them, purposely designed that way. And the water part of the fluid part of the blood gets pushed through that, and the cells stay back and go back in the body. That fluid part of the blood, now called a filtrate, gets modified in the tubules. A person will make about 25 liters worth of filtrate. So if the kidneys don't regulate that, you got to be drinking 25 liters worth of water every day. That's a lot to be drinking. But it gets modified here. They hold back salt, they hold back fluid, they hold back some proteins, they regulate sodium, they regulate potassium, they regulate acid in the body. And by the time they come to the collecting system, and then all collect together to go down to the bladder, you're left with approximately 1 to 2 liters a day on average. Some people a little bit more, some people a little bit less. And that's a much more manageable amount of fluid that you can keep up with by eating and drinking. So just to say this once again, the glomerulus filters the toxins, the tubules regulate fluids, the salts, the acids. The interstitium is there, and there are the interstitium helps with the regulation of fluids. The vasculature is the blood vessels coming in and out, and the urinary collecting system funnels the urine after it's been made into the bladder. Well, there are diseases that you may have heard. There are lots of diseases out there that hit the kidneys, some of which you may have heard, and some of which hit specific parts of the kidneys. The glomerulus is notorious for being hit by a disease called lupus. You may have heard of lupus. Fairly common disease in the United States. It's a lot of women, can hit men, more women than men, but it's fairly common. And lupus is notorious, along with other autoimmune diseases, for hitting the glomerulus. Iga Nephropathy is another name which I'm sure most of you have never heard of. You may have. Is actually not all that common here in the United States, but it's actually one of the most common glomerular diseases in the world, hitting mostly an Asian population. So it's actually fairly common in the world, just not here in the United States. HIV we've all heard of. That can hit the kidneys. I have someone right now, we just started on dialysis, unfortunately. I saw someone in my office just last week who HIV may be hitting her kidneys, her HIV medications may be hurting her kidneys. We're in the process of figuring that out right now. And of course there are lots of other diseases that hit the kidneys and hit the glomeruli. Oops. Tubules. Remember, the tubules are involved in fluids and acids and salts. Tubules are hit by other types of diseases. Let's say you come into the hospital and you've had the stomach flu and you've been having diarrhea and you haven't eaten, you haven't been able to keep any food down, you've been nauseous and you've been vomiting for the last 5 days. And your blood pressure is low because you're now dehydrated, and maybe you've gotten sick on top of that, and you're now what's called septic, so your blood pressure is even lower. Your kidneys are very sensitive to that, and the cells in the tubules may die off, at least for the time being, and that's called ATN, Acute Tubular Necrosis. Dehydration, even before it gets to that point, can hurt the kidneys. That will recover if we just give you fluids. Contrast, people may have had CAT scans, or fairly commonly people go for cardiac catheterization. You come in with chest pain. Someone in their 70s or 80s comes in with chest pain. The kidneys may not be perfect to begin with, and their cardiologist says, "Oh, we looked at your EKG. We need to look at the arteries of your kidneys, of the heart." They're going to feed a wire up through the groin into the heart and inject what's called a little bit of contrast. Contrast means that it shows up under X-ray. So look at an X-ray while they're doing this, and it shows up as a white line. And through that, they can see the arteries in the heart. That contrast can also hurt the kidneys. So those are other places that we see kidney problems, notoriously in the tubules here. The interstitium, notorious for allergic reactions. You may have heard recent reports of what we call the PPIs, Nexium, Prilosec, medicines like that, are now thought to be involved in more, people who take those have more kidney problems. Not clear where that's from, what that latest data is from, but we think in the kidney world that it's probably related to allergic reactions to those medications and those allergic reactions are found mostly in the interstitium, between all the other cells. That's not to say those medicines aren't safe. I actually believe they're quite safe, as long as you're not reacting to them. The vasculature. Well, vasculature, the blood vessels, hypertension, notorious for causing problems on the blood vessels. Not just in the kidneys, but in the heart. Elsewhere, I can look in your eyes with an ophthalmoscope and sometimes see effects of high blood pressure in the eyes. That's the only place I can actually look directly at the arteries. And sometimes I'll look there and see high blood pressure, sequela from high blood pressure in the eyes. Some autoimmune diseases can hit the vasculature also. The urinary collecting system. Okay, picture an 80-year-old gentleman. We're all going to get there, myself included, you included. We're all going to get there, and our prostates are going to get large. It's just what happens when we as men get older. Some people, as their prostate gets enlarged, will start blocking the outflow of urine from the bladder. You close down on what's known as the urethra. That blocks the outflow of urine from the bladder. That urine will back up and back up into the kidneys. I specialize in kidney stone prevention. I see it all the time. People come in and they have a stone. They formed a stone that's now dropped from the kidney and gets gets lodged in the ureter. That's the tube between the kidney and the bladder. Gets lodged there, and the urine now backs up. The urine can't come through, and they develop some kidney failure from that. These often can be reversed, but we have to find it. We have to know about it. How do we find out about this? So if someone comes in with a stone, they're going to feel it generally. But the vast majority of people who come to see me, they have no idea that they have kidney problems. They no symptoms, no nothing. They were found, they went to their doctor, they had a checkup, maybe they got labs for some other reason, maybe they were going to get a test and they needed labs beforehand, and they got blood work, and they were found on the blood work, their number on the blood work that looks at the kidneys was found to be elevated. That's the vast majority of people. We don't generally find symptoms of kidney disease until very late, until the kidneys are very far gone, actually. Now that's fortunate on one end, but that's unfortunate that often people won't be able to pick up on this. And it's really only by labs that we find most people. The blood chemistry, that's blood work, and the urinalysis. You may have gone to your doctor and had one of these cups. That's the urinalysis. And I look for protein, I look for blood, and those are things I look for in the urinalysis that may clue me in to something going on with kidneys. I pulled off the internet, so I have no idea whose this is. I looked for one of mine, but I couldn't find one of mine. And if we can find the pointer, there we go. So this is a blood chemistry. So Na is sodium, potassium, chloride, carbon dioxide, anion gap is something more special, glucose, something we look for diabetics, BUN and creatinine. Creatinine mostly is what we look at. And that's the number that your doctor may pick up on. That creatinine, non-toxic, doesn't hurt you. It's a breakdown product of muscle, actually. Yes?
Questions for later, but that OSM thing there, right? Where it says 279?
OSM, osmolarity.
What does that mean? And could that number be like 311? Could that number be?
The osmolarity is reflective of other anions and other proteins in the glucose, other constituents of the blood that are take up that have osmolarity.
Also, that has nothing to do with calcium and salt.
Calcium is involved in it, but in a very minuscule way. Sodium, on the other hand, is one of the major what we call osmolar agents in the blood.
So could that number be 311? If it's 311, what does that mean? Is 20% too high or too much?
No. I'd have to look at the rest of the blood. If I had someone who had a sodium of 145, which is the up end of normal, right there, just from the sodium, their serum osm would be 290, just from that. I add in, let's say their glucose is maybe a little bit elevated, maybe they've been eating a lot of protein, and maybe they're on steroids and BUN is a little bit elevated. So we add in those things and we come up with the osmolarity, and that's what it's reflective of. So 311 is not per se elevated, but it depends on what the rest of the blood looks like. I'm not sure why it's there. I don't generally get it on my routine labs. I look for it. I use it in very specific situations where someone's sodium may be too low. I look for it. That's the main, or where the potassium is off. Those are the main uses for me for it. Now the creatinine, as we said, is a breakdown product of muscle. Everyone has muscle in their blood, in their body. There's a constant turnover of muscle, and with that, creatinine gets into the bloodstream, and the kidneys filter it. It's the only place that the body gets rid of creatinine. So if that creatinine goes up or is elevated, either means you have lots of muscle. So I have a linebacker for a former pro linebacker in my practice. His creatinine is generally running about 1.8 to 2, and gets everyone worried. But when we do the better test to figure out what his kidney function is, it's all normal. And it's really because he's so muscular. On the other hand, I've had patients who've been in nursing homes for years, and they haven't moved from bed. And they come in with a creatinine of 1.2, I can remember 1.7. That was actually quite bad for her because she had very little muscle mass. So it can be reflective of that. More commonly, it's reflective of the kidney function. Let's say that number goes from 1.2 up to 2, very reflective that there's been a change in kidney function. So those are the two places where that comes from. And that's why we use the creatinine as the marker for kidney function. If you come to my practice, I want to know where all this is coming from. I'm going to sit there, I'm going to ask you lots of questions. I want to know, before I even go up to examine you, I want to have an idea of where your kidney function problem is coming from. And I ask you lots and lots of questions, some of which you may have, if you look closely, you may see you have diabetes, do you have cancer, do you have HIV, lupus is on there somewhere. Have you been exposed to different chemicals? Have you had kidney stones? Here's one, Advil, Motrin, Aleve, ibuprofen, very common. I have someone unfortunately in the hospital right now that unfortunately we're going to have to start on dialysis because he was taking so much Advil that it hurt his kidneys. So yes, it's not common, but it does happen. So these are the questions I want to know when you come to my office. Now, how's your doctor going to figure out whether you have kidney problems? We know the blood work, we talked about that. You may get a urinalysis. So urinalysis, if I see protein in the blood, protein in the urine, that may be indicative of certain things going on. If I see blood in the urine, that's indicative of certain things going on. I'm going to look for the different salts in the urine. That's going to tell me what are the kidneys thinking. If the kidneys in the body, water follows salt. So if I eat lots of salt, think of someone who maybe has congestive heart failure. Maybe you know someone with congestive heart failure who they're told not to eat lots of salt. Why not salt? Why are they told no salt, but we don't tell them so much about fluid? Because whatever salt they eat, that fluid's they're going to hold on to that fluid. So I want to know whether the kidneys are holding on to salt. If they're dehydrated, there's going to be very little salt in the urine. And these are clues that I use to figure out what's going on. I want to know what their total kidney function is. And rather than just calculate off the blood, and that's an estimation, maybe some of you have seen this. So I'm going to give this to the patient, they're going to collect the urine for a whole 24 hours. Yes, lots of fun.
Our donors have...
Right, the donors, you've probably seen this multiple times, unfortunately. Or fortunately for the recipient. It's a pain, but it's how we compare patients across the population and how we figure out what their kidney function is much more precisely, and whether it's important to go ahead with further testing, or whether we can just sit back and watch and see what happens. We may also want a sonogram. I couldn't bring a sonogram machine, but I could at least bring some bad pictures that I downloaded off the internet of a sonogram. Yes?
Can we talk about the bilirubin? That touches upon this also, I think, right?
I'm sorry?
Bilirubin.
Bilirubin.
The bilirubin generally is not kidney related. Bilirubin is generally liver related, and it's related to breakdown in blood, and also related to how the liver conjugates and gets rid of toxins that are not water soluble, not kidney filtered, but are liver metabolized.
Thank you very much.
So I apologize. I'm not going to be able to expound on that too far.
I apologize too.
No.
Sorry.
So sonogram, we'll get a sonogram. These are pictures of the kidneys. I want to make sure there's no blockage. Remember we talked about blockage as being one? Well, I want to make sure there's no blockage. Maybe there's a kidney stone sitting in the ureter that's going to show up as, that's a relatively normal kidney. But here you can see the collecting system all blown out, all enlarged. And that's what we call hydronephrosis. That's where we see blockages. That's what a blockage of the kidney looks like. I'm going to look for different autoimmune diseases. And I want to know I want to find the cause of these things. So I want to know how I'm going to treat. If it's an autoimmune, I'm going to suppress the immune system. Lupus, for example, we give steroids. Steroids you may have heard of. Prednisone, Solumedrol, these are medications you may have heard of. These suppress the immune system. Sometimes we even take it a step further, where we need to give agents to the strength of something like a chemotherapy agent, something that might otherwise be used for a leukemia or lymphoma, but we use it here to block kidney disease, block autoimmune diseases in the kidney. We want to control the cause. A fairly common type of leukemia is multiple myeloma. I know in our community, as a doctor, I'm in tune to it, so I don't know if other people are, but I know that there are people in our community who have multiple myeloma as a diagnosis. Myeloma is notorious for hitting the kidneys, So we want to, if that's the cause, we want to go after that. We want to find it so we can shut down the myeloma. We all know we need to control blood pressure, control diabetes. As I mentioned before, NSAIDs, Advil, Motrin, Aleve, fairly common meds that we all use, notorious for hitting the kidneys if you use enough of it and use it on a regular basis. So I want to make sure that my patients avoid them. A couple years ago, there was a group at Columbia that found that Fleet's enemas, of all things, hurt the kidneys. So I tell my patients, please don't use Fleet's enemas. Used to be fairly common, people would get colonoscopies. So anyone over 50 nowadays kind of become standard of care to get a colonoscopy at age 50. Fleet's enemas used to be fairly common as the prep, what cleans out your colon. In my part of New Jersey, now the gastroenterologists use very little of it because they've learned that this can hurt the kidneys rarely. Now what are we going to find as people's kidneys aren't working? And again, generally symptoms aren't found. You're not going to have symptoms until it's fairly late in the game. Unfortunately, you're not going to know it except by the blood work. But we do know that at about 40–45% of kidney function, people start having issues with calcium and phosphorus in their blood. And that affects the bone strength. There are hormones that their levels go up and they can hurt the bones, they can weaken the bones at that level. Below 30%, we see some anemia. The blood counts start dropping. Remember, the kidneys are involved in keeping the bone marrow stimulated. And we see people, their cardiovascular risk, their heart disease risk starts going up. Below 20%, we start seeing more electrolyte issues, more salt issues. We start regulating their diet much more carefully. People who have kidney disease at that level start having problems regulating their sodium, their salt. They have problems regulating their potassium. So we start putting them on low salt diets. This is just an example. Tomato juice is very high in salt, very high in potassium. So they need to start, we tell them stop eating potassium-rich foods. Orange juice is something else that's very high in potassium. Bananas, avocados, potatoes. Very common foods we all eat. But these are foods that patients who have kidney disease now need to restrict. Phosphorus. Milk, very high in phosphorus. We take it for granted. But patients who have kidney disease now need to restrict that. Especially when they're on dialysis, they need to restrict that. Yes?
Isn't calcium deposits a major cause of kidney stones?
Calcium is involved in the vast majority of kidney stones, but interestingly, calcium stones are not, people's risk of kidney stones is not increased by the calcium that they eat and drink. Because it actually binds the components that are making the stones, it binds it in the gut, as opposed to allowing the calcium to bind it in the urine. So it's actually counterintuitive at first, but yes, you're right, calcium is definitely involved in stones, but actually we actually encourage people for those types of stones to actually have calcium. So it's a little bit counterintuitive, but you're on the right track. Below 20%, again, more severe electrolyte issues, more severe anemia. You may have seen commercials in years past for something called Procrit. It used to be very common in the oncology world. It was given all the time in the oncology world, now very little, but we still give it in the renal world, the kidney world. And those are shots, that's the hormone that the kidneys used to make, but now aren't making, to boost the bone marrow to make red cells. So sometimes we need to give that. Below 15% is when we start seeing uremic symptoms. Uremic symptoms meaning buildup of toxins. People may have nausea, they may have lost their appetite, they may have hiccuping, they may have itching all over. Metal taste. For lack of a better way to describe it, I ask my patients, does it taste like you're chewing aluminum foil? And these are the things that people with severe kidney disease start feeling as they're approaching dialysis. And these are the symptoms I'm looking for every time people come to my office to see, is it time yet? Is it time yet? Are you at that point? Because now, how do we treat some of these things? When people are below 45%, we'll give them some vitamin D that helps to regulate the hormones that are involved, that are upregulated at this point. Below 30%, as I mentioned, we'll give them shots of Procrit. We'll give them iron if we need. We start talking what are your options? You know, if you're going to be progressing, what are your options? Are you going to need dialysis? Should we be looking transplant? We start talking about diet, and we start getting people listed for transplant because we want them to accrue time a year or two before they go on dialysis, so their time is shortened. In New Jersey, the wait time is 4 to 5 years. Here in New York, I think it's 5 to 6 years for a deceased donor kidney. So we want them to be prepared ahead and get that time ahead, so when they're ready, if they don't have a living donor or they can't avail themselves of renewal, their wait time is much shorter. At 20%, we start preparing them for dialysis. We start talking, how are you going to do dialysis? We don't want people to do dialysis. If we have to do it emergently, we have to put this into their chest, and this hangs out on their chest. They can't take showers. It's a place that infection happens. We don't want this. We want people to get what's called fistulas, and those are surgical hookups in the arm where the needle's on dialysis, and we'll show you what a dialysis machine looks like in a second. But that's how we can get the blood for dialysis. And then below 15%, once their symptoms are at the point where they need it, we start talking dialysis and arranging for dialysis. The 3 types of dialysis. There's hemodialysis, that's hemo, blood. So we access their blood, we clean their blood, and we put it back in them. There's peritoneal dialysis, and that's where we clean the blood, clean the body by putting clean fluid into their belly. The toxins diffuse into that clean fluid. We take the fluid off, we put more clean fluid in, and it's an ongoing process. And of course the third way, not dialysis per se, but the third way we replace the kidneys is by transplant. Again, hemodialysis, blood is cycled throughout the body through an artificial filter. That's this. We'll see it. I'll show you a little bit more detail in just a second. Peritoneal dialysis, we put fluid into the belly, and transplant, you get a new kidney. Hemodialysis, you can sort of see, couldn't bring a dialysis machine, but you can sort of see the machine here. Some of you may have seen one. And blood is, this gentleman. Pointer. This gentleman has a fistula there hidden on the other side of his arm, the surgical hookup where the needles are put in. The blood is taken out. That's the pump on the machine. It's pumped through the tubing and ultimately goes through this kidney. If I get this right, blood comes up through the kidney, and there are about 1 million tiny little straws in here. They're very, very tiny. If you can come up later and take a look at it, or I can pass it around. About 1 million of these tiny little straws, and these straws have tiny little holes on the sides. So the blood comes up through here. The holes are too small for the cells to come through. They're too small for most proteins to come through. They're just the right size for sodium and potassium and that size of electrolyte to come through. Even phosphorus, which is another electrolyte, which we all know is tiny, it's a molecule, is actually doesn't easily come through those holes. So the blood comes up through here. The components we don't want get filtered out, and there's clean fluid that comes the other way, passed on the outside of these straws, and that allows the toxins to filter into the clean fluid. The blood goes back in the body, clean fluid now is dirty, goes out, and more clean fluid is put in, and it's done on a continuous cycle. People sit on a machine for 3.5, sometimes 4 hours at a time, 3 times a week. I have patients who are even on 5 hours at a shot. It's a lot. It's a very big commitment, and it's major change in lifestyle. It's major issue because this is a big deal now. It's major time commitment, and if they don't do it, they can die. But that's hemodialysis, and this is this thing cut open here. I can pass this around. We can pass this around.
Yeah, sure.
And that's a picture of this guy cut open. Like I said, about 1 million of these little straws coming through. Peritoneal dialysis. Fluid is put into the belly. People get a tube that stays in their belly. Clean fluid is put in. Has all the right levels of electrolytes. And because there's lots of membranes in the body, in the abdomen and the pelvis, the toxins diffuse through those membranes into this clean fluid. We pull that off and put clean fluid back in, and it's done on a continuous basis. And that's how we clean the body and clean the blood that way. I'm sorry?
It's like a flushing out kind of
Right.
evolution.
And PDs actually, after the first couple of months, people actually do it by machine. Machine, they hook up at night, done for 8 to 10 hours overnight, and that's about the size of the machine. You can see it's about the size of a large laser printer. And they do it overnight, and they do it actually while they're sleeping. For the vast majority of people can do that. So in that regard, it's a much more convenient way of doing dialysis, but it's still dialysis, and it's still a very big commitment. Kidney transplant, here we go. This is where the kidney actually goes. I don't know if we call that the stomach, I call it the pelvis. So it actually goes right in here. And it's hooked up, right in here are the femoral arteries and the femoral veins, which are very accessible when the body's opened. And it makes for a great place to hook up the arterial. You need artery, you need blood flow into the kidney, and for the veins, because you need blood flow back off the kidney, back to the rest of the body. And those veins and arteries are very accessible here, and the bladder is sitting right here, so it's very easily accessible anatomically. And as you can see, that's basically how they do it. It's not a 5-minute operation, as we're talking here, it's a multi-hour operation, but that's put into a nutshell. What should you do as a patient? We've talked about kidney disease, we've talked about how it's found, we've talked about what are the different causes of kidney disease, we've talked about what does kidney disease do to a person, we've talked about how do we take care of it. What do you as a patient? What do I as a patient? And when I go see my doctor, what do I want to know? I want to know, again, I want to know if my kidney function is okay. I want to know what my blood chemistry shows. I want to know, is my creatinine normal? I want to know in my urinalysis, is there protein, is there blood? These are things that I want to know about. And if there's a problem, maybe it's selection bias, but as a nephrologist, I would want to see a nephrologist, or I would want my patients to see a nephrologist if they're having issues. Because as a nephrologist, a kidney doctor are the ones that are most trained to deal with this and to figure out where the causes are and how we're going to take care of it. What if you don't have kidney disease? Baruch Hashem. Thank God. But then you should be talking to Rabbi Sturm. If you don't have kidney disease and you're healthy, there are lots of people who need kidneys, and lots of people out there who can benefit from your kidneys. So it's a fantastic way, it's a fantastic thing that we should all explore if we're healthy enough, and think about donation. I think that's, again, thank you to everybody, thank you to Dr. Bright, thank you to Rav Sturm for making the shidduch.